Today, spend our time a little bit on invasive coronary physiology testing. So in terms of what we do in the cath lab, this is like the antithesis, a little bit of my Bill and Jamie fellowship of all the high risk and very complex things last year. But I think actually it's challenging in other ways and is a tool that we can really use to help guide our decision making in the cath lab. And so I'm going to take our time today to discuss that and how we can use it in a variety of scenarios. There we go. I have no financial disclosures related to this talk. So I think one to start with, I just wanted to call out that in all of the testing that we describe and in our clinical decision making in stable ischemic heart disease, it's a little difficult to really establish what our gold standard is for ischemia. So of course we have a variety of stress tests that are compared to one another in terms of their predictive value that varies by the patient population. But in a lot of those, are you then correlating your stress test findings with angiography or later presentations at MI? Even in the era of high sensitivity troponin, there's people who have entire Twitter accounts basically dedicated to the fact that there's lots of mild troponin elevations that maybe aren't ischemia driven in a clinical sense that we typically think about that. In addition, you know, interventional cardiologists don't agree on a lot of things, but we definitely don't agree on what percent stenosis many lesions are, especially in a more intermediate range in larger vessels with different takeoffs or diffuse disease, and that's been well demonstrated as well. In addition to that, I think we're in an era where we're calling into question how much does it matter if we establish ischemic burden, and does revasc in stable ischemic heart disease really benefit patients? And there's been a kind of abandon the mantra that we're preventing heart attacks and saving lives by fixing a 50% stenosis for good reason, but on the piggyback of courage and ischemia trial, I think that's balanced with, as a transplant center and LVAD group, we've certainly have seen patients that despite medical therapy have progressed to pretty severe LV systolic dysfunction. So if we believe in ischemic cardiomyopathy as a mechanism in these patients and driving some of their poor outcomes, obviously there's somewhere in the middle where we want to intervene on patients and prevent further poor outcomes like heart failure, repeat admissions for MI and death. But that patient selection has become more and more tricky in the realm of stable ischemic heart disease. And so while we overall have been able to take a little bit of a slow roll into that in terms of focusing on symptoms, I think there's still a lot of challenging decision making when we get patients into the cath lab. One common scenario that, and this is a case that kind of drove a lot of this home for me in my fellowship, patient situation is pretty common for us, to the fairly young woman who was referred for stress testing as part of her renal transplant evaluation. And for her, she performed well on the treadmill. She had no chest pain. She made it to 11 meds, normal exercise tolerance, but the test was interpreted as distal septal ischemia, as well as mild hypokinesis in the anterior wall. And so with that, she was referred for angiography. Again, she's pretty young. She doesn't look like off the street, doesn't look like anybody who would have epicardial coronary disease, but has risk factors of kidney dysfunction. And she has, we see here, pretty unremarkable circumflex system, modest territory, and an angiographically somewhat ambiguous lesion in the proximal LAD. Here we see a pointer here. So we see some distal disease in the LAD as well. But we have her on the table and we say, well, now what? So she has no symptoms. We see some things in angiography that are a bit of an eyesore, but where do we go from here? Do we just provide PCI to the proximal LAD? I don't know how severe that is. Do we just full metal jacket the entire LAD and commit her to all those stents? Or do we say there's diffuse disease and we should refer her to cabbage? Or none of that matters, she's asymptomatic and she has normal LV function, so we should proceed with medical management. So one of the things that I want to highlight today is to convince you that we can apply the principles of invasive physiology testing to help us make these decisions in the cath lab. But even though this is maybe not the bulk of the cases that we see, this is a lot of what's happening out in the world and something important for us to emphasize, I think, to guide patient care and ways that we can apply this to manage epicardial disease, but as well as to help in diagnosing causes of angina without obstructive epicardial coronary disease, which we'll talk about a little bit later. So to start off with coronary physiology, it's a little bit of alphabet soup when you're reading these papers. And so just to re-review some of our understanding of the coronary vasculature and how the different aspects that we're looking at, with the epicardial coronaries are, of course, a large part of our focus, but actually a minority of any of the resistance in the coronary vasculature bed, which is predominantly all contributed to by the microvasculature, and precapillary arterial is included in that. So what was originally evaluated back in the 80s even was Coronary Flow Reserve, which was just looking at the actual ratio of your maximal blood flow through the entire coronary bed through hyperemia, so maximal amount generated, and that as a ratio for baseline flow. And so basically it's just your reserve to augment blood flow in the coronary vascular bed across the board. This didn't have any direct patient kind of interventional applications because it doesn't tell you if there's any issue here or if it's in the microvasculature bed. And it's also fairly challenging to do. Currently, we haven't found a group that has immediate access to that in Washington State, so it kind of tells you where that went over time. Since then, what we're going to focus on a lot of today, we've been using something called Fractional Flow Reserve, which is just focusing on the resistance in the epicardial bed. Again, normally in normal epicardial coronaries, you don't have really any significant resistance through the larger arteries in the epicardial system. And so what we're measuring there is any stenosis in an abnormal disease state that contributes resistance there. Relative to that, what we'll talk about a little bit later is some metrics that we can use for microvasculature assessment, which in some camps include, is focused on CFR, and others are moving towards IMR, which is a measure of resistance in the microvascular bed. So kind of with that in mind, Fractional Flow Reserve is really not rocket science. There's a more complicated derivation here, but generally speaking, if we assume that the coronary quote wedge pressure or right atrial pressure is fairly minimal compared to our aortic pressure, that simplifies to just simply the pressure that we measure distal to the lesion on a pressure wire compared to our aortic pressure, which we're measuring with the guide catheter simultaneously. So what this was aimed at was evaluating intermediate stenoses, so those where we felt like on angiogram it was somewhat unclear whether they would benefit from revascularization of that lesion. And initially, this was evaluated in terms of single vessel disease, comparing that to non-invasive stress testing, and using a benchmark of 0.75 that correlated very well to other stress test modalities like nuclear stress, stress echo, or even just ECG. One caveat is that this does require a hyperemic condition, because the goal is that you're reducing the resistance in the microvasculature as much as possible, and under that steady state that we can use pressure basically as a surrogate for flow and to identify whether that obstruction is significant. So once they had evaluated these benchmarks, they went on to do clinical studies. Most of you are familiar somewhat with the FAME trials. FAME 1, or the first FAME trial, randomized 1,500 patients to FFR-guided PCI with stable multivessel disease. So the idea was that these patients had multiple vessels that were concerned for greater than 50% stenosis, and essentially using the FFR to guide which lesions to revasc versus just proceeding with revasc of effectively all of those that they felt were where that was necessary. There was a change in the primary composite event rate, which was basically used in all these trials, where, back to here, the basically all of them use a composite of depth MI or repeat revasc, and a common theme is that repeat revasc is really what's driving a lot of that. Although, as we'll see in FAME 2, that was then applied to look at FFR-guided PCI, just performing PCI in those lesions that were significant versus just optimal medical therapy alone for all of those. In that case, all the patients had FFR, and so this was really to test not only whether it was safe to defer stenting in some of those, but if we found a benefit now over just optimal medical therapy in these lesions. And in this case, one thing to know is that the threshold has changed from the original studies because they felt like there was a gray area there where we may be missing significant lesions. And so a threshold largely used in what's applied clinically is that of 0.8. In FAME 2, the combined endpoint was reduced substantially at 1.6% in the group that received FFR-guided PCI versus the optimal medical therapy group at 11.1%. But again, this was largely driven by urgent revasc. It is important to note that the trial was stopped early at the recommendation of the monitoring committee due to the significant difference in the endpoint. And so there is some consideration of whether if they had continued that, they would have been powered to see a change in individual endpoints of MI or possibly death as well. But those were just a trend and not statistically significant in those trials. So we had some clinical data to suggest that using physiology was better than just angiography guided PCI alone. We used fewer stents, that reduces costs and serious complications, and that was safe in terms of patients coming back to the cath lab. And then we found in theme 2 that it was better to use FFR guided PCI rather than just optimal medical therapy alone for all of these intermediate lesions that were found on angiogram for patients referred due to stable angina. But the uptake of physiology is rather slow. It's not very well captured in a lot of our registries because we typically are capturing those who go on to intervention and not those who we perform physiology on and then don't proceed with stenting or CABG for that matter. We do have some, this is data from industry, actually just looking at uptake and the general kind of penetrance of that in the United States of adopting physiology is about 20 to 25%. It's actually quite a bit higher than these other countries in red where that's estimated to be less than 5%. Looking at some other ways to evaluate kind of how likely people are to want to use physiology. This was a survey that was sent out in Europe. At the time, the European Society Guidelines for Stable Ischemic Heart Disease recommended a class 1 indication for using FFR if there was an intermediate lesion without prior other non-invasive stress testing or ischemia measurements. And so they sent out a survey basically to review 12 different cases, just under 500 people responded. And what they found there is, as you see these little black circles here, each column relates to the coronary for that case. And so for case 1, for example, each of these dots relates to entries by participants for the LAD. You can see that, again, if we're just looking at interventional cardiologists responding at least to this survey, but I think we can probably across the board, there's quite a bit of variability in intermediate lesions in terms of how everybody calls that out in terms of the percent stenosis. We see a fair bit there. The red circle there was what they used as QCH or angiographic derived measurement to look at the diameter stenosis. In addition, all of these patients were real cases where FFR was performed and they had those results, but that wasn't divulged to the participants in the survey. So what they were asked to do is rate whether they would just proceed with PCI based off angiography alone, or the survey response could request FFR or imaging. In the green columns here, that's the proportion of people who did request that they would proceed with FFR at that time, versus the gray scale, which is where they would do IVUS, so intracoronary imaging to help guide whether or not to perform PCI in those cases. And these were all vignettes with stable ischemic heart disease presentations and angina without other testing. Altogether, the use of FFR in this kind of simulated survey environment was quite low. One responder requested using it in 10 out of the 12 cases. That was by far the highest. 27% actually never said that they would use FFR to help in any of these scenarios. And interestingly, if they looked at the responses of the practitioners of whether they would go on and stent that lesion that was that they saw on the angiogram, about a third of the decisions were discordant with the FFR results. And these were real cases where that was performed. And so, you know, obviously this is limited by survey data and response rate and all the other things, but I think highlights some things that we feel to be true in our general practice, looking at care variability in the way we look at this. And so I think there is an idea that we can still do a little bit better in applying physiology in intermediate disease. As we know, trying to decrease the burden and decrease our use of PCI in unnecessary cases. So one way that folks have been looking at doing this is to minimize our need for hyperemic conditions, which require the administration of adenosine in the cath lab. A couple of our cath lab nurses here who can tell you that they really love mixing that and giving it to the patient, who then complains of chest pain and usually other symptoms during that case. And I think, you know, starting in the phase where we were using FFR only and administrating adenosine, it's not the end of the world, but you certainly are talking the patient through it to get them through 2 minutes and try to achieve that benchmark where we're evaluating our physiologic testing. And so one argument for kind of the so-called resting indices where you don't need adenosine is that just that will increase the uptake across the board of interventional cardiologists actually using this in the lab in real world use. So the idea between IFR or instantaneous wave-free ratio as a resting index is they looked at FFR under hyperemic conditions, and then also looked at the wave tracings in patients with their resting conditions. So they did different derivations to try to identify this so-called wave-free period where you don't have the compression and decompression waves from pressure propagation in the microvasculature, and you have generally a nadir of coronary resistance that's fairly stable, and the deceleration of pressure velocity, flow velocity, is also at a fairly constant rate. And so using that, they derived a benchmark of a cut point, which does operate on a different number. So remember, our threshold was 0.8 as a more inclusive threshold for FFR. For IFR, they derived this to be 0.89, and so that's one thing to take note of. But effectively, they did some validation studies just comparing FFR and IFR in the same patient to choose that benchmark. Then for clinical applications, IFR was then compared in randomized trials to FFR in randomized fashion in 2 major trials. Both are fairly similar. There's Sweetheart and Defined Flare were the 2 where they did this. So these were non-inferiority trials compared to FFR, so they weren't driven by the primary clinical event rate. But in Sweetheart, it was an open-blinded, open trial where patients were randomized to one or the other and had similar event rates as we see here, where IFR had a combined endpoint of 6.7% versus 6.1%. Defined Flare was actually a blinded trial, but only included stable ischemic heart disease patients, and these curves were similar but just reversed. So overall, similar results where IFR was not inferior to FFR in these trials. Of note, they did find that more lesions were assessed in the IFR groups in these studies, even though the protocol asked that you complete FFR for all intermediate lesions. There's some speculation that the adenosine administration and patient symptoms, which because chest pain was reported at a much higher rate in the FFR group, then maybe that limited the application of the protocol. So overall, I think one of the arguments for FFR by folks who've been using that is that the original clinically driven trials were performed in that population, and we're using IFR as a comparator only to FFR, but it was non-inferior in these 2 trials. And so some of the debate comes out of those clinical endpoints, but there's also a lot of debate of kind of the physiology nerds in our cohort of looking at the discordant readings for IFR or CFR, and which one might be more accurate. The way that they've reconciled a lot of this kind of relates to how this all goes back to CFR or coronary flow reserve. But the idea being that coronary flow reserve, while not very useful in the cath lab in our acute decision making, does have a relationship to long-term MACE events. And so if we look at the discordant measurements of FFR and CFR, the groups who are normal on both tend to do very well. The groups who are abnormal on both tend to do poorly. But if we're looking at folks who have abnormal CFR rates and normal FFR range, in general, that's thought to be predominantly microvascular disease, which makes sense. Remember, FFR is only measuring our epicardial flow. But those patients still had maybe a higher rate of poor clinical outcomes. And this was looked at in a small number of cases, but in patients with up to 10-year follow-up, so a reasonable link there to sort of advocate for that. Once we add IFR to the mix, looking at IFR and FFR discordance with her relationship to CFR, see that IFR tends to more closely relate to CFR, probably because of some of those principles and lack of kind of dependence on hyperemia, which the whole point of that is to reduce the resistance in the distal microvasculature as well. So there are some camps that believe that IFR may be more accurate at predicting clinical events, but again, I think at this point, a lot of that's speculative. In practicality, we use these at largely just different measures for the same goal, and depending on what's available in the lab. There may be times where with modern systems, you can actually perform both very easily with the same pressure wire. So there may be times that we can use both to kind of look at those differences as well. In terms of discordant IFR and FFR results, there was another group that looked at how this may relate to the pattern of disease. And so I think one interesting thing there is the idea that with FFR lesions, you can have kind of a minimally moderate to moderate focal stenosis, but under conditions of maximal hyperemia, if you have a patient who can really augment their blood flow, then you'll still get a pressure drop if that flow is augmented to a very high degree. And whether that's really clinically significant in those cases where it's just such a dramatic change in flow, driving that pressure drop is maybe a little less clear. And altogether, when they looked at the pattern of atherosclerotic disease in those cases, they indeed found that FFR positive lesions that were negative, this is negative by IFR, tended to be more focal lesions, whereas those that had IFR negative lesions IFR positive lesions with a negative FFR tended to have very diffuse disease. And so it did appear that there was a change, in the overall resistance across the lesion, but that perhaps this was just very diffuse disease. And so this is a case where I think the pullback can be really helpful for us in evaluating whether treating the lesion we see on angiogram is actually related to an improvement in the flow there. There's been some interesting look in a recent trial where they actually performed IFR before and after PCI, and it was interesting to find that maybe up to 20% of cases, even after the stent goes in, we still have abnormal results. Now, whether that's due to mild ischemia that's generated and some things that maybe change the microvascular bed during our intervention has been proposed, but I think the other idea is that if you have really diffuse disease, even if we stent the part that's more proximal, we have distal disease that we're not improving by our intervention procedure. And so the pullback pattern has become quite useful in our decision making in the cath lab. As opposed to focal disease, where you get a very discrete step up, the idea is if we increase the diameter right at that lesion, then you're probably going to reduce a lot of the resistance there in the epicardial bed. And that patient's more likely to benefit from PCI. So back to our young lady who had end-stage renal disease and an abnormal stress echo with anterior wall ischemia. Her IFR we repeated like 3 times. I think I did this with Katie Dawson because it was so highly positive at 0.39. Remember, 0.89 is kind of our benchmark cutoff. But after normalizing again and repeating it, it was quite a bit positive. She did have a step up right here at the proximal lesion. It was fairly minimal in the distal bed. So we went ahead and proceeded with IVUS-guided PCI to her proximal LAD. She got a 3.0 and then followed up in renal transplant clinic. And just because they were doing all of this for part of her transplant evaluation, she actually ended up undergoing an additional stress echocardiogram. She felt similar and performed similarly, but this one was now interpreted as normal. And she is now actively listed, but has not yet been transplanted. So, I think obviously the decision-making in the pre-transplant group is different kind of across the board, but this was a case where just by the angiogram, I wasn't that interested in the proximal lesion and almost would have missed it initially. But I don't know what that is. Exactly. But I think that it's a case where physiology really helped us to make decisions that I think hopefully help her have a better long-term outcome and avoided the need for just jailing her entire LAD with a full middle junctional stent. So taking a step back, in what clinical scenarios are FFR or IFR clinically relevant? All of these were designed to look at intermediate lesions by angiography and stable ischemic heart disease by design. There were cases, as I mentioned in the Sweetheart study, they included ACS in about 17 to 20% of the cases were that, which were also unstable angina. But in those cases, it was the non-culprit lesion that was assessed. We didn't go through some of the other STEMI trials, but again, we're using IFR, FFR in those cases to guide the non-culprit lesion. There is some concern that with acute coronary syndromes, especially with a large transmural MI, that you have microvascular dysfunction that would affect those results. And so many cases there might be, there are those that advocate for performing that at a separate stage scenario, and that we don't need to do all of this in one setting in the cath lab. There's also some concerns about using these tests in the post-CABG population. It really hasn't been validated in doing this through vein grafts or potentially in native vascular disease, that are grafted and you're assessing a different lesion there. In theory, the total flow should be, still relevant here, and so we can often use this still to guide decision making, but there are many who advocate in those cases. If you're doing it down the graft, you have to be really careful about normalization and some other things that are typically fairly of minimal importance. Things like change in the height relative to where you normalize. I'll see in the graphs, but you may travel several centimeters from where you're normalizing down to the actual lesion if it's in the native bed. Distal to that, and all of that can change our interpretation of that aortic pressure to distal pressure ratio. There's a number of technical factors as well. So remember, our aortic pressure is related to that we're measuring off the guide. So if we have a guide that's too large or an osteo lesion, then we can have guide dampening, and that can affect our results as well. So those are all things that we're trying to watch each other. Getting the wire down is really simple, but making sure we do a good job doing the test takes an extra minute. There's also, I think it's kind of often forgot scenario where severely elevated LV-EDP can affect our results. So in some studies where they looked at patients with high LV-EDP and actually lowered that with nitroprusside, they estimated that about 1 per millimeter mercury increase in your LV-EDP was a little less than 1/10 of a point change in your FFR. They didn't see as much change with that with IFR, but I think those are small studies and hard to tell. So overall, if you have a very high elevated LV filling pressure, we have to have the caveat that you might have a falsely elevated FFR and thus potentially a false negative result. It's also been looked at in a TAVR population pre and post, just because FFR is a little bit more sensitive to things like flow pre and post because of the critical aortic stenosis, and probably some factor of that is also related to LV filling pressure. So I think with those caveats, we can apply these to a lot of patients in the stable ischemic heart disease population. One other scenario, I mean, I can't give a talk without showing one CTO angiogram. So this is a 49-year-old woman with lupus who had an RCA CTO that was referred to Dr. McCabe for her ischemic cardiomyopathy. She actually had autoimmune hepatitis related to that, was also undergoing a workup for that, and requested revasc to make her eligible for liver transplant. So you can see here she has kind of a serial lesions here in the proximal to mid-LED, right by that pretty sizable diag for her. That's fairly focal. The distal LED looks good. She also has a very large collateral coming off the distal LED septum. So this is her PDA filling late here, and she has a mid-RCA CTO. And so at the other institution where the angiogram was performed, she did undergo IFR testing of her LED, and that was significant at 0.87. So we see, and looking at the step up on pullback, we see that there's a fairly focal step up. So you would imagine that treating both areas of that lesion would improve her epicardial flow. But the one caveat here, and this is on interventional boards, I had this question. I'm actually not sure what they're getting at because they don't always have to for CTO PCI. But this is a scenario where you can actually have a mildly abnormal physiologic test of the LED related to coronary seal from the collateral supplying the RCA. So in her case, she underwent successful RCA CTO PCI with Dr. McCabe. You can see the PDA now is filling antegrade. She felt so much better when she came back for the staged LED intervention. We decided to repeat her physiology testing at that point. You can see the collateral flow is fairly minimal now that she has competitive antegrade flow. And on repeat testing, the FFR was 0.84, so very much in the non-significant range, and so stenting was deferred. She actually did go on to liver transplant. Looks like she unfortunately died of complications after the fact related, but was able to feel well, had resolution of her angina, and was now eligible for liver transplant. So I think that this just highlights that we have lots of tools within cardiology, and just like all of the other tests that we're ordering on a daily basis, our physiology in the cath lab is a great way for us to guide decision making, but we have to look at it through the whole clinical picture. And this is one case where we were able to avoid additional intervention in this woman. I'm just going to spend the last few minutes to pivot and talk about physiology and provocative testing to evaluate angina in folks who have refractory angina and present to the cath lab but do not have obstructive epicardial disease on their angiogram. And this is something that we're kind of just rolling out at our institution. So we've had some recent interest in that, and went down to Stanford and looked at the way that Tremble and her group are doing their protocol, basically to try to offer something to these patients that are on the other side of the spectrum, don't have any obviously treatable epicardial disease, but maybe have syndromes that we don't fully understand and can further guide and tailor their therapy. So back to our coronary bed picture. So again, we're looking at IFR, FFR, and epicardium. IMR is related to the resistance that we're detecting in the microvasculature. And so we need to use that or CFR in conjunction with IFR, FFR to evaluate whether the microvasculature has additional burden of disease that could be potentially contributing to angina. In addition to that, we often use acetylcholine for provocative testing, which is really to look for endothelial dysfunction related to coronary vasospasm. And this is gaining some traction. In the last set of European guidelines, there was a 2B indication to do provocative and invasive physiology for refractory angina evaluation in folks who didn't have obvious obstructive coronary disease on The idea behind the provocative testing for coronary spasm is to evaluate for endothelial-dependent function, which is separate from the endothelial-independent function that we're measuring in the flow reserve. And so the idea is that acetylcholine, which is an endogenous substance that is normally acting as a vasodilator in the epicardial coronary bed, promotes the release of nitric oxide, and then that dilates both the epicardial and the microvascular bed. Once you have disease, which can include atherosclerosis, you can have aberrant reactions to that where you actually get vasoconstriction in response to acetylcholine. And in addition to that, even when atherosclerosis is not observed on intravascular imaging, you can have a highly reactive endothelium for reasons that we don't fully understand, where patients actually can have a vasoconstrictive response. And so what this is the kind of the mainstay of treatment, mainstay of diagnosing patients with abnormal vasocoronary spasm. This is similar to ergonovine, which had been used for years, but it seems to be less reproduced. The acetylcholine is more reproducible in identifying patients with spasm there, and also because it has kind of a normal vasodilatory response in the normal endothelium, seems to be more specific, whereas ergonovine typically will cause vasoconstriction to some degree. So we're asking people to identify whether that's a 30% stenosis, which is normal, or 90% which is abnormal. So again, I mentioned this is a 2B indication right now in the European guidelines, but if we're looking ahead, I think this is starting to gain some traction. So just recently, Core MICA is a group who looked at providing this testing as a way to try to classify patients with refractory angina, but no epicardial disease on angio, and I think in a pretty elegant way. So I just want to spend a minute going through this trial. I think it was part of what was influencing us in our decisions to try to offer this to patients. So they approached patients actually before they had their elective angiogram for stable angina. There was over 1,300 patients that were evaluated. The majority of them were excluded largely for patient preference, and some that were just not approached due to logistical reasons before they actually proceeded to the cath lab. So informed consent was obtained actually before the angiogram in 391 patients, about 200 of which had obstructive coronary disease that were excluded based on that basis. But of the remaining 151 that were randomized, they actually all underwent coronary functional testing and additional physiology. But in those that in the intervention arm, those results were provided to the caregiver, which was different than a different person than the PCI operator. And those results gave some tailored recommendations and actually labeled the diagnosis based off their physiologic testing. On the flip side, in the control group, they also had the functional testing, so we knew the diagnosis in the study, but the person actually providing their primary cardiovascular care didn't receive any of that information, and just got a general letter saying, this is how we generally recommend treating coronary vasospasm, this is how we treat microvascular dysfunction. And the main take-home points there were that in the 75 patients in each arm, they were assigned a diagnosis of either microvascular angina or vasospastic angina based on the acetylcholine testing. And if they had totally normal results across the board, then they were given a diagnosis of non-cardiac testing. The therapy was then provided to the primary care cardiologist, stratified by antianginals and other non-pharmacologic modalities as well. And the main results that they found are that patients did have an improved score of angina by the Seattle Angina Questionnaire that was continued from 6 months to 1 year. And they also had other benefits in terms of their quality of life metrics. And so overall, I think another interesting takeaway from the study is fairly broad patient population with a high burden of angina and high burden of comorbidities. But in looking at them, the minority of only 11% actually were diagnosed with non-cardiac testing. And so another small percentage of them at 17% just had what appeared to be pure vasospastic coronary syndrome, in terms of which the medical therapy is fairly different. And one of the kind of characteristics of this is it's not does not respond well to beta blockers and may actually be exacerbated by that. And the majority of patients were on beta blockers coming into the study, and that's what we see in general practice as well. They do use a fairly stringent criteria, which is kind of the generally accepted idea by the groups that really focus on this patient population, which was a greater than 90% epicardial stenosis in reaction to the acetylcholine. The patient also had to reproduce their angina on the table and have evidence of ST. In addition, there were the other half of the patients actually were diagnosed with coronary microcirculatory disease. In those cases, they can still have a reaction to the acetylcholine, often angina. They have less than 90% stenosis on the angiogram itself. And the idea there is that because the microcirculatory bed can respond to acetylcholine with dysfunction as well, they can have angina, but we're not going to see that in the epicardium on the angiogram. So across the board, they looked at quality of life and illness perception and angina, with the main benefits being related to sustained perception of quality of life by the patient and their angina scores. So I think, in general, what we're trying to offer here is a diagnosis for patients who feel kind of lost out in the world. They have many repeat presentations. They often have undergone several angiograms. They maybe are admitted for MI on multiple occasions. And by providing a diagnosis and a pathway that we can perhaps prevent a lot of that and decrease some of their stress, as seems to be shown in this similar trial here. Now, what do we do with microvascular disease? I think there's small trials that showed some benefit of ACE inhibitors, statins, et cetera. We tend to treat with the same anti-anginals. So I think in this group, it's a little bit hard to say. We're limited also by the fact that in early studies, a lot of these folks were clumped together as syndrome X. So they had an angiogram that didn't identify a lesion that we thought needed to be stented or received balloon angioplasty at that time, or CABG, and then they were all just lumped into a group and received various medical therapies in small numbers. And so I think that makes it a little bit harder for us to derive any real conclusions about what the best therapies are. But we have some general strategies. And in the vasospasm group, it tends to be fairly different because we really focus on calcium channel blockers with nitrates as a second-line therapy. There are some new modalities looking at endothelium receptor antagonists as a targeted therapy. And so it's a fairly small patient population, but so far those things have been promising. And in general, we're avoiding beta blockers. So I think in the last minute here, just to briefly remark for that, especially the microvascular disease group that has refractory angina, there are some things coming down the pipeline that we may be able to be involved in on the trial circuit. One of which is the coronary sinus occluder for refractory angina. Basically, you're placing a device here which is going to reduce flow in the coronary sinus, and the idea is that by increasing that venous pressure, you might actually increase some of the perfusion pressure in the microcirculatory bed. For what it's worth, in a small trial, it seemed safe and had some small efficacy, but we need more data on that. And then some of you in the room, I think, know a lot more about this than I do, but we are hoping to enroll patients in some stem cell therapy trials as well, which have been promising in some early, very small trials. And so I think especially the microvascular disease population maybe has something to gain from these new therapies. So in conclusion, I just wanted to point out today how physiology-guided PCI is associated with improved clinical outcomes, and kind of remember that as we're incorporating our thought process of how we use angiograms to guide therapy in the context of a lot of the other trials that we're looking at in terms of, going forward. I think we're interested in those complete revascularization, improve outcomes in the long term for patients and prevent things like ischemic cardiomyopathy. But should that really be guided by things like physiology in the cath lab and not our eyeballs detecting a stenosis and deciding what needs to be stented? In addition, I think, in the cath lab, they say we have two decisions. One is whether to treat, and the second is how to do a good job. And some of these modalities really help us to focus in on what's most likely to benefit from an increase in diameter from our stent therapy. And then finally, that in those with refractory angina without obstructive coronary disease, I think that some of this physiologic testing appears to provide a quality of life benefit and reduction in angina, just by tailoring their therapy in a way that we don't typically do successfully in clinical practice, at least with our current metrics.